But yeah, I can just start the introductions. So good morning, good afternoon, good evening, everyone, depending on where you are. So just a little information, closed captions are being automatically generated. So you can press the CC button at the bottom of your screen to access those. We also have a Q&A box. So if you have any questions for the speakers, could you please put them in there? Because the second half of the webinar will be a discussion and we'll answer the questions then. If you also can't see the slides, please exit the webinar and come back. We've had issues like this beforehand and just exiting was fine. It fixed the problem. So my name is Sarah Bourdin and I'm delighted to welcome you all to this fourth webinar in MeSH's webinar series, the Strengthening Routine HIV Data, a Female Researcher's Perspective. The aim of this series is to discover the perspective and work of brilliant women in the HIV field. And these women will discuss their contributions to strengthening the understanding, collection, analysis, and use of routine HIV data towards the aim of accelerating and tracking HIV decline in sub-Saharan Africa. So just a little bit about the MeSH Consortium. So the MeSH Consortium is part of the London School of Hygiene and Tropical Medicine, and it aims to maximize the potential of data routinely collected through HIV surveillance and service delivery platforms, as well as provide timely information on key outcomes within relevant populations. So please make sure to follow us on Twitter and our website for updates on the series and just in general. My colleague Tom will just put those in the chat box now, the links to those if you just want to have a look. Yeah, I think we can maybe start. So it gives me great pleasure to introduce Morna Cornell from the Southern Africa Data Center based in CHER at the University of Cape Town. And she's going to be presenting our great fourth webinar. So without any further ado, I'm going to hand it over to you now, Morna.
Thank you very much. And thanks to the MeSH Consortium for the invitation to talk today in this series on women in science. I was asked to start with a personal take. The series is not just about presenting research, but really about researchers as people, and particularly as women. And so I'd like to describe my rather unusual journey into science and how routine data helped to identify a major gap for men in HIV programs and in public health more broadly. I live and work in the global south, in sub-Saharan Africa, the epicenter of the HIV epidemic, which is home to 2/3 of all people living with HIV. South Africa has been called the most unequal country in the world. Sorry, that's too fast. South Africa has been called the most unequal country in the world. About half of our population lives below the poverty line, and about 1/3 are officially unemployed. We have overlapping epidemics of poverty and inequality, with the largest number of people living with HIV worldwide and an extremely high TB burden, about 60% co-infection with HIV. We also have endemic rates of unnatural deaths, increasing rates of non-communicable diseases, and a COVID epidemic in a still largely unvaccinated population. And the exposures and outcomes of all of these are highly gendered, but poorly understood. I am the 6th of 8 children in a highly academic family. You can see in both of the photographs, I have a stripy top on, with a remarkable mother as a role model, who instilled in us a strong sense of social justice and human rights, and the clear understanding that we had responsibilities beyond our own lives and concerns. At school, I had zero interest in science. It was very badly taught by people who did not understand it, and they certainly didn't enjoy it. And I decided that I'd only study once I knew exactly what I wanted to study. And so instead, I spent about 15 years being bored. And then in 1992, I found meaningful work. Between 1992 and 2000, I ran the AIDS Consortium, which is a national network of individuals and organizations fighting for the rights of people living with HIV. And this was at a time when people with HIV had no guaranteed rights, and levels of discrimination and stigma were incredibly high. The consortium was a broad coalition with different priorities, but we all agreed that people living with HIV were entitled to human rights, and we organized around that. Running the AIDS Consortium was an excellent fit for me. situations of great injustice where there were lots of battles and the chance to make a difference in people's lives. This was also a time when HIV was literally a death sentence because we had no treatment. And underlying our work was the fear that everyone we knew with HIV would die, and far too many did. In the early years, babies and women were described as innocent victims and thus deserving of rights. And so in the 90s, our first fight for treatment was for AZT to prevent HIV transmission to babies, and then for dual therapy to keep the mothers alive. Then in 1996, I was at the AIDS conference in Vancouver, which entirely changed the landscape. There was the groundbreaking announcement that triple therapy could stop the virus from replicating. And suddenly there was the possibility of life, if you could afford it. In 1998, I went to the Global AIDS Conference in Geneva, misleadingly entitled Bridging the Gap. It aimed to bridge the treatment gap between richer and poorer nations. But at the time, as the Lancet editorial noted, the big debate is going to center on equity in treatment access. And I'm sure this sounds familiar, 25 years later, we're again seeing massive inequities, this time in access to COVID testing and life-saving vaccines. So for many of us, what became increasingly clear was the massive and widening gap between the global north and the south, with the north having many publications and the south having the large populations under study. And we felt a growing rage at the uncrossable divide between those who could and couldn't pay for life, and the fact that some lives seemed to matter more than others. This anger gave rise to civil society coalitions for social justice. And I was a founder member of one of these, the Treatment Action Campaign, you may know as TAC, in the late 1990s. And we brought together a wide range of treatment and human rights activists, providing treatment literacy so that people with HIV could advocate for their own health. We undertook legal challenges, for example, forcing government to provide treatment to prevent HIV transmission to babies. And we led legal and illegal protests against Big Pharma. And people living with HIV put their bodies on the line, participating in clinical trials with no guaranteed post-trial access. Again, sounds a bit familiar. These actions helped to reduce the cost of triple therapy to an affordable generic combination within a few years. And the drug companies, of course, were still making enormous profits. So this all took place against the backdrop of high-level government opposition in South Africa. From a health minister who resisted giving AZT to prevent HIV transmission to babies, to a president who denied a causal link between HIV and AIDS, and then a subsequent health minister offering beetroot and garlic as alternatives to antiretroviral therapy. But eventually, in 2004, kicking and screaming, South Africa started its antiretroviral program. And today we have the largest program worldwide with over 5 million people on treatment, which is a remarkable achievement given our context. Meanwhile, in 2002, I co-authored a book on our explosive HIV epidemic. And from 90 diverse conference papers, the major thread was what it means to be a man or woman in Southern Africa, and how this understanding impacts on HIV risks. And this really was the start of my thinking about sex and gender differences in HIV. Before I go any further, I'd like to just have a note on terminology. The World Health Organization defines gender as the characteristics of women and men that are socially constructed, and sex as those characteristics that are biologically determined. When I started doing this work, the term gender was used very loosely, particularly in medical literature, and it included sex, noting that the effects of gender and sex are often intertwined and difficult to disentangle. More recently, the understanding of gender is increasingly contested, and the terrain is far more complex than these definitions suggest. In this presentation, I'm using gender for consistency, although there may be instances where the term sex is more precise. South Africa has an excellent record of clinical research. From 2002 to 2007, I worked in HIV research in CHER SA, which was a huge multi-site NIH-funded program of research, exploring ways to implement public sector antiretrovirals in resource-constrained settings. This study by Sana et al. Provided crucial evidence that nurses could deliver antiretroviral therapy, which supported task shifting in situations of limited resources. Another CHER study you might have heard of was the CHER trial among HIV-positive babies, where immediate treatment reduced early mortality and HIV progression by 75%. The study changed global pediatric HIV guidelines and was an unusual example of research speedily translated into practice. Working in CHER was an amazing opportunity. I had no scientific or other training, but I sat on the scientific advisory board and I participated in all discussions with global HIV scientists. And this exposure triggered an interest in science and HIV research. And I realized that at last, I found what I wanted to study. So in 2005, as a very mature student, I started tertiary studies for the first time at the age of 46. I specialized in epidemiology and biostatistics, 30 years after doing any math, and I learned the value of good evidence. In the last year of my master's, I was offered a job at UCT, and so for the next few years, I juggled 2 posts and completed my master's, the first to do so at UCT without an undergraduate degree. And then my PhD, which I did on the evolution and effectiveness on the South African antiretroviral program. In the UCT post, I managed and undertook research in a new regional scientific collaboration. Established in 2006, IDEA is a global scientific collaboration with 7 regions, which collects and analyzes routine pediatric and adult data from large antiretroviral therapy programs to answer the kind of questions that can't be answered in single sites or with small numbers. The primary aim was to research antiretroviral initiation and outcomes over time, and we had very long follow-up within our cohorts. And this has now been expanded to include a range of comorbidities. Our regional collaboration, IDEA Southern Africa, has 2 data centers, one at the University of Cape Town and one at the University of Bern. With the highest HIV prevalence worldwide, our region has data on 1.3 million patients, followed for over 3.6 million person years. So building on my earlier interest and using IDEA SA data, I did my master's thesis on gender and survival in an antiretroviral program in Cape Town. And I found that men indeed had higher mortality than women. And my literature review confirmed the prevailing wisdom, which anecdotally blamed men for their own poorer outcomes, along the lines of, you know what men are like. They won't go to the doctor. When they do, they're older and sicker. They don't take medication regularly, and they're more likely to be lost to care. But I was uncomfortable reading these generalizations repeated as evidence. And so in 2012, I revisited the issue in one of my PhD papers in a much larger study using routine data from 8 large South African cohorts. And here I'd like to make a few comments on working with routine data, which are probably familiar to many of you. Some of the challenges we've encountered include combining messy data from multiple sources, missing data, including no data pre-art, inaccurate measurement and recording of measures, and variables that are defined differently, including, importantly, outcome variables such as loss to follow-up. We also have out-of-range lab values, implausible dates where someone died before they started treatment, and unreliable variables. So for example, one of our variables was ART naive, and about 10% of patients were recorded as ART naive, but actually had suppressed viral loads when they were supposedly starting treatment. A further constraint is that in sub-Saharan Africa, we have limited ability to ascertain patients' true outcomes. This is in the context of massive, rapidly expanding antiretroviral programs and limited resources, where there's high loss to follow-up and sites have little capacity to actively trace patients. Of course, tracing studies can be done on a sample of loss to follow-up, but that's expensive and time-consuming. In addition, few African countries have got good vital registration, which we've seen again in COVID. And so many outcomes may be misclassified, and it's largely deaths that are misclassified as loss to follow-up. And in our experience, we found that site-reported mortality may be underreporting true mortality by 50%. Some of the approaches that we've used to try and address these challenges were multiple imputation, multiple data checks, obviously, exclusion of extreme values or dates, very usefully a standardized definition of loss to follow-up, that we could apply across all the cohorts, which allowed for some comparability. We also have a unique advantage in South Africa. We have a well-functioning national population register, which captures about 94% of deaths in people who have identification documents. In our studies, 75% of the patients had IVs, and so their data was linked. And so we had really good mortality ascertainment. And we were also able to confirm if patients were alive or dead after they'd been lost to follow-up. So what did we find? Our analysis included 46,201 adults starting treatment between 2002 and 2009, predominantly female, about 65%, with a median age of 35 years. And men certainly had poorer access to treatment because they only comprised 35% of those on treatment. And in later analysis that I did, this proportion did not increase 1% over 12 successive years of enrollment. At ART initiation, compared with women, men were older, 38 compared to 33 years. They had more advanced HIV disease, so their median CD4 cells were lower, and a larger proportion of them were in WHO stages 3 and 4. Compared with women, men had a 46% higher crude mortality risk over 3 years. But when we adjusted for variables that were measured at ART initiation, this was reduced to an adjusted HR of 1.31. So starting men earlier would reduce their mortality risk compared with women, but it would not remove it. And these gender disparities in age, CD4, and mortality were consistent across all 8 cohorts. So we wondered, could differential adherence patterns explain the mortality difference? We don't collect a formal adherence measure in our data, so we use virologic suppression as a proxy. We found equal proportions of viral load data in men and women, and equal proportions virally suppressed. The different adherence patterns did not seem to explain the mortality difference we were seeing. We also explored mortality after loss to follow-up, as I said, using data linked to the National Population Register. And we found that men were more likely to be truly lost to follow-up, which we had defined as still alive 3 months after loss to follow-up. And we found no gender difference in mortality after loss to follow-up. Then we looked at immunologic responses. Women started on average with higher CD4 counts, which we know predicts CD4 trajectory, and they had better immunologic responses. But even in a sensitivity analysis, limited to patients who reached a CD4 of 200 or more after a year and out, the gender difference in mortality persisted. And virologic responses, as I said, were similar with no evident gender difference. And when we restricted to those virologically suppressed at 12 months, men still had higher mortality. So in terms of the explanations, men being older and sicker at start explained some, but not all of the excess mortality. We found no evidence that men were less adherent to ART or more likely to die after being lost to care, and their biologic responses were similar. So I really wrangled with why this was the case. Why was mortality then higher in men? And then I had my aha moment, and I suddenly thought, I wonder if there's a difference in HIV negative mortality. So with my co-author Lee Johnson, we compared mortality in patients on antiretrovirals with HIV negative mortality. This graph compares male versus female mortality in HIV negative individuals and those on ART, and an estimate greater than 1 shows increased mortality among men compared with women. The dotted blue line is the age standardized HIV negative mortality ratio, and the solid red line is the observed mortality for men compared with women on ART in our cohorts. And as you can see, not only was there also a mortality difference, it was actually far greater in the HIV negative group, suggesting that just being in HIV care appeared to protect HIV positive men against some other mortality risks. We also found that with duration on ART, the proportion of mortality unrelated to HIV increased from 5 to 36% in men and 3 to 25% in women, which opened a new public health discussion that people living with HIV don't necessarily die of causes related to HIV or antiretrovirals, and that men face far higher background risks than women of dying, largely due to violence, road traffic accidents, and suicide. Since then, I've seen increasing evidence of gender inequity in HIV programs across sub-Saharan Africa. Women have higher incidence and have thus been appropriately prioritized for targeted funding and programming. They have better access to treatment and they have lower mortality. In contrast, men are far less likely to be tested and start treatment, sicker and older when they start, with a higher risk of death. But this is only evident if you disaggregate. You'll be familiar with the UNAIDS ambitious 1990 targets to end AIDS by 2030. These required that by 2020, 90% of all people living with HIV should know their status. Of these, 90% should be on treatment, and of these, 90% should be virally suppressed. Across sub-Saharan Africa, men have done far worse on the first two 90s for testing and the initiation of ART, consistently over the years. But this is invisible if the data are not disaggregated. For example, in West and Central Africa in 2019, an overall estimate of 68% tested masked a disparity where only 63% of men versus 78% of women are tested. And similarly, an overall estimate of 85% initiated on ARTs masked the far lower enrollment of men. And indeed, the largest single gap in HIV services in sub-Saharan Africa is 700,000 men aged 35 to 49 who do not know their HIV status. The WHO explains the critical importance of disaggregating data for health systems. Most importantly, this provides information to allocate appropriate resources. That's excellent advice. But if it really is critical, why did the WHO only start reporting disaggregated global health statistics in 2019? How were resources allocated appropriately without this information? And then I found that this neglect was not restricted to HIV. It was also evident in many other health conditions. Since the first ever reports, TB incidence, prevalence, and mortality have been higher in men than women. Yet TB programs continue to focus on women and children. So much so that it's been called a systematic neglect, which reinforces gender inequalities. This neglect is also not limited to low and middle income countries. The Lancet produces the Global Burden of Disease Study, which combines data from over 200 countries, again explicitly intended to help set funding and program priorities. Yet it did not report the statistics disaggregated. In 2013, Hawkes and Buse reanalyzed the data, disaggregated, and found that men had a higher burden of disease and lower life expectancy than women. And again, it raises the question, without disaggregation, how were the priorities set appropriately? But even when data are disaggregated, scientific journals may not report appropriately. In the 2018 Burden of Disease study of global TB, men comprised 2/3 of the HIV negative incident cases and deaths, and over half of those in the HIV positives. Yet these critical findings were absent from the summary, the research in context panel, and the discussion, none of which even mentions that being male was a major risk factor for TB. I believe that research that ignores gender inequities helps to perpetuate them. And in a recent example, the UN General Assembly issued a 19-page declaration to, quote, end inequalities and end AIDS by 2030. It notes with concern that sub-Saharan Africa remains the worst affected region and that men have poorer outcomes across the HIV cascade. Yet it only calls for urgent and exceptional action to curb the effects of the epidemic on women, adolescent girls, and children. But this is why I came to see men as the elephant in the room. This growing body of good evidence documenting men's poorer access and outcomes in healthcare, but global and national policies and responses that specifically target women. I don't believe there's been a conscious decision or desire to exclude men. And I also think that the early gender focus on women's health was appropriate in the context of deeply entrenched patriarchal power dynamics. But too often, gender is still conflated with women. Gender and health are seen as a zero-sum game in which men and women are competing populations and men are somehow less deserving. The language we use is critical. So when gender is regularly conflated with women, it doesn't seem odd to see, for example, the UN Interagency Network on Women and Gender Equality, the SDG 5 goal of gender equality and empowering all women and girls, the UN AIDS operational plan for women, girls, gender equality and HIV, etc. Once you become aware of this bias, you notice it everywhere. I challenge you, the next time you see the word gender, see how soon you see the word women. And of course, this also reinforces the gender binary and risks excluding trans and non-binary people. Certainly, historically, and in many situations, men have greater social power and privilege than women. But men are not homogeneous and all-powerful. This conceptual framework from the Lancet Gender series shows how men, like women, are born with sex and immersed into the gender system, and their gendered pathways to health or ill health are influenced by their sex, race, class, age, and ability. And of course, we also need to consider the impact of colonialism on the health of marginalized populations, including indigenous men, and the impact of apartheid in South Africa, with its appalling migrant labor system, which tore families apart and disempowered hundreds of thousands of African men. So, for example, this recent blog about COVID points out that men from marginalized groups, and I'd add disability to this list, are not necessarily privileged in health and may face higher morbidity and mortality. So having seen this gap and the lack of progress over many years, I realized that evidence alone does not change much. National programs have got 5, 10-year plans. These are hard to change. They're cumbersome. Funders have got vested interests, long-term commitments, targets and required outputs. International health agencies have agendas about gender and health, which are slow to change. And the gender space is sensitive and difficult to navigate, which may partly explain why so little progress has been made to date. But I believe that researchers can play a pivotal role in informing policies and practices, and also making a message as widely as accessible as possible. So from 2011 onwards, I reverted to advocacy, highlighting the evidence about gender disparities in HIV care and in public health more broadly. Together with others, I use good evidence to try to improve men's health in projects including trials of novel interventions to engage and re-engage men in HIV care in Malawi, a collaboration between academic researchers and community-based organizations in Cape Town, leading Idea Southern Africa's new cross-cutting theme on gender equity, which we hope will inform all future analyses in this regional collaboration, and the Bridges Project, which is building local capacity to produce good quality research on HIV in men. In recent years, there's also some progress at the international level. We helped organize the first Men and HIV satellite session at the 2019 AIDS conference in Mexico, and then the follow-up satellite session at the 2021 virtual conference. I'm also a commissioner on the Lancet Commission on Gender and Global Health, where I'm trying to make sure that men are not left out of the gender discussions, and advising also on the upgrading of the UNAIDS website on men and HIV. The WHO has a working group on men and HIV, largely at the moment focusing on voluntary male medical circumcision and HIV self-testing in the workplace. There are, of course, also alliances such as Promundo, Men Engage, Global Action on Men's Health, among others, and some national policies on men's health. But progress is slow. And I actually believe that we need a paradigm shift if we are ever going to reach universal health coverage and truly leave no one behind. We can no longer, at best, consider men's health an optional add-on, provided it doesn't take away energy or funding from the health of women and children, on the basis of men's right to health and effective public health responses. I was asked to reflect on my journey in science, particularly as a woman. And thinking about that conceptual framework that I showed earlier, I'm not sure that my gender has necessarily been the most important influence in my journey. At different times, I think that my education or lack of education, class, race, HIV status, age, and ability have all impacted more than the fact that I'm a woman. In many ways, what has been most important has been being an outsider, not being a lawyer or a medical doctor or a scientist in environments where these professions were particularly valued. Being heterosexual, classified white, HIV negative, and older. Being an outsider has given me insight into the huge challenges facing young African researchers, often writing in their second or third language in cultures which do not celebrate self-promotion. And as a result, my two main areas of work now are raising the profile of men's health for a more equitable response to HIV and mentoring young African scientists, mostly women, to produce high-quality African-led science and hopefully start to transform the current situation in which the North leads most papers and the South provides the data. But without question, the most significant and pervasive influence in my life and career has been my mother, B. Cornell, and her deep commitment to social justice. Thank you, Mom. Finally, I'd like to acknowledge those who died without treatment, those who fought for treatment, sometimes with their lives, and those who continue to provide treatment under very difficult circumstances. I acknowledge my funders, and thank you for your attention.
Thank you so much, Morna. That was wonderful. It was a very beautiful talk, really interesting and really clear. I really enjoyed it. Yeah, I had such a great flow, and I loved how personal you made this talk, and it was lovely to go through this journey with you. So yeah, thank you for that. And I think it was very interesting to have as well, you know, your perspective from the side of activism. I think it's a very interesting insight. As researchers aren't always so multidisciplinary, and I think it's nice to have that kind of diversity and have different experiences and different people working on something. So yeah, thank you for that. Thank you for the talk. So now we're going to pass on to the Q&A, and I want to make this as interactive as possible. So please make sure to add any questions you have into the Q&A box. You can also raise your hand, and I can give you the floor to ask your question. But I just kind of like to start off with a question of my own. And usually I ask a question about, you know, your experience as a woman within the field, but as you know, you've already covered that, and you rightly also mentioned the fact that there's an intersectionality to being a person, and that it's not just gender, but it's also class, race, disability, and so on. And yeah, so you've basically already answered my question. Thank you for that. But I had another one actually. And so it was about when you were talking about the work that you did on loss to follow-ups. And I was wondering if you tried to contact those that were lost to follow-up and see the reasons for their loss to follow-up, because I think that would be extremely useful to then getting them, well, fixing those problems would be useful to keeping them within care. So I just, yeah.
So as I said, we work with routine data that's provided to us. So the data that we've got, it's anonymized, first of all, and we have no direct contact with, obviously, with any patient. We don't know any details about the patients. In terms, so we would not be we would have no capacity to do anything like that, and also that isn't really our role. But within IDEA Southern Africa, we have actually had an interesting, in the last 2 years, we've had a tracing study going. We've been looking at pediatric tracing as well. And some very interesting, but you know, tracing studies are good, but they're really expensive, and it's a big undertaking. So obviously, what the tracing studies do is that they give a whole lot of sort of you can actually get a lot of, as you say, kind of qualitative. You can actually understand some of the reasons for that, but we're not in a position to do that. I do have there are a couple of questions here, and if
I mean, I'm happy to lead on those.
To those,
but,
yeah.
Yeah, I just wanted to, I guess, just following up on that. Yeah, so we're doing, and I don't know if Tom, you want to talk a bit more about that, but we did a tracing study in Zimbabwe as well, and it's true that it's a very complicated undertaking, but it was quite interesting to see results from that, because it is also important to know why certain populations aren't continuing to access care. I don't know if you want to add something on that.
Very interestingly, just to sort of hammer home my point, a systematic review was done in the last year or the year before, where they were looking at retention in care. And they found that in all the studies that they looked at, there was not one that looked at the retention of heterosexual men in care.
Mm,
Some small studies on men who have sex with men, but there was nothing that looked at heterosexual, not one study trying to actually keep
mm.
it. So just to
That's very interesting. Yeah, absolutely. I mean, so the study that we did was within it was with a sex worker clinic. So we didn't have that kind of population. But yeah, that's very interesting that not one study looked at heterosexual men in care. Yeah, I don't know if you wanted to add something, Tom, or not.
No, I mean, I guess, yeah, just to follow up on that, obviously this is a female sex worker focused study, but it's interesting to think about the differing reasons for disengagement and how they intersect with each other, including kind of movement and, ongoing needs, etc. So that's one thing we're currently looking at.
I mean, I think what we really know is that loss to follow-up is such a gray black, if it's black box, gray box. We just, it's a mixture of so many different things. And what more and more is happening, of course, is that we realize that lots of people are cycling in and out of care or moving self-transfers as well, which we recorded.
So I'll ask a few. So we've got quite a few questions. So I'll ask the first one. So this first one is from Brian Rice. And he says that it's interesting to hear about your advocacy and research work and your personal journey. Given the numerous areas we could still be doing better, you highlight well a number of these. Do you feel activism and campaigning still plays the role it should? If not, why not? What more should be done?
But I definitely, thank you, good question. I definitely don't think activism plays the role that it does. I think that activism around treatment for HIV was a very clear human rights issue that you could pull a lot of people together around who maybe had different points of view about other things, but we all knew that was important. I think that now it's much more diffuse, and so there are smaller marginalized groups that have managed to get their voices heard. I mean, we look at over the years, sex workers have been very successful and men who have sex with men have been very successful in getting their issues onto the HIV agenda. I would say that heterosexual men don't really have kind of a voice in the same way. And the question is also, if not, why not, and what more what could we be doing better? I think that, Brian, what I don't see much of is that link between research and the broader masses, basically. So first of all, getting your messages out accessibly so that people actually can really understand the issue without being too technical. And then also trying to change things. So, coming up with interesting findings and then actually trying to do something about it instead of you publish it and then you move on. So, it's obviously very different perspectives. I'm not a pure researcher, as you can see. I've got into research and learned some of the tools. I did it. I found this big message, and that's kind of really what drives me now. I don't really do analysis much now. But I think that's part. I think that could be done much better. I think that if people are, if you find something of interest that is relevant, that is important, you should also be looking to ways. Yeah, we should be looking to ways to get that out more, and also challenging where those practices are bad.
Yeah, absolutely. Thank you for that. So I've got another question now. This one's from Vario Abdullahi. And they're saying, what has been the overall response to your research and findings on men and HIV, given that the spotlight is often on women's health, like you said in your presentation?
Thank you. Thank you very much. Interestingly, I would say that generally speaking, if I had the chance to talk through like this, to talk through and to kind of take people with me on a journey, I have had almost no resistance. Most people are kind of amazed, and really it's like, I actually never thought about it like this before. And the next time they see the word gender, they're looking for how quickly they see the word women, things like that. So a lot of the time when I speak, sort of individually to people, but obviously there's also a huge pushback. So certainly the funding environment and the international health agencies, there's a huge focus on women and women's health, as I say. And I've said in other talks that, I've never heard somebody stand up to speak about a women's study or massive funding or whatever that's going to women's health, first prefacing it with saying something about, well, I don't want to take away from men's health, but blah, blah. But every single time I ever hear anybody talk about the few initiatives that there are with men, they have to start out being quite apologetic and say, we don't intend by this to take away from women and children, but we just kind of like to squeeze in something for boys and men on the side. So I've had kind of quite different reactions, some incredibly hostile reactions. But generally I find that actually if people take the time to listen through it, it's almost kind of like, oh, I never thought about that. So actually quite a good response.
Very interesting. Thank you for that. So now I've got a question from Paul Me. So Paul's saying, thanks, Morna, that was an excellent presentation. And your comments echoed many of my beliefs about the marginalization of men. I would be interested to hear more about your ideas and how we may overcome the barriers men experience to accessing and remaining engaged with care. So this is kind of what we discussed a bit. I'm particularly interested in the role HIVST has in giving men more agency about their engagement, but know the issues are wider.
Absolutely, thank you. Good. So I think in terms of the barriers to accessing and remaining engaged, it's actually in the last 2 or 3 years, there's quite a lot of work happening with that. So there are a number of studies that are looking at this, randomized controlled trials that are trying different approaches. I think what we're really looking for are numerous entry points into care for men. There's been an assumption that men do not visit facilities, so we can't offer them anything at the facilities, and there are all sorts of assumptions are made about men, as you can hear. And a colleague of mine, Kate Dowell, has done really interesting work in Malawi where they're testing quite a lot of these assumptions. And they found, for example, that in the last 2 years, 80% within a group of about 2,000 men, I think it was, about 80% of them actually had been to a facility for something or another in the last 2 years. So it could have been after testing, predominantly in the outpatients department. So that's, I really think this is somewhere we need to be thinking about more and more, is different places to offer it. Where do we find them? Offer it there. And the other interesting thing that they challenged was this notion that men do not provide care, that men do not look after children and old people, because about 40% of these men had actually attended as a caretaker. So I think there's really interesting work being done, starting to try to find different ways of getting men into care. The remaining engaged in care, if I could answer your question, I think I probably have a lot of money. I think that certainly things like HIV self-testing offer very interesting options. Of course, there is also the point that people who've been tested at home may not have then had to go through the barriers that other people men would have experienced going into facility, and they're still going to have to go there and start treatment. So there may still be a problem after the HIV self-testing. But I think that certainly HIV self-testing, I think that giving men more agency, giving them a little bit more pride, treating them as human beings was a good point. And then I think looking at what these studies are coming out with, some quite big studies. There's one big one in KwaZulu-Natal in South Africa. There were a couple actually happening across South Africa, and there were a couple happening in Malawi that I know about, where they're actually trying different approaches and seeing what works.
Yeah, I've seen a few of these, and it's quite interesting to see the different ways in which to try and get men more engaged, or at least like testing more. So now we've got a question from James Hargreaves. So James is saying, thank you, Morna, that this was wonderful. I wonder if you could reflect a little on what approaches you think look promising in relation to closing the gap for men in accessing HIV testing and treatment. So kind of a similar question to
I think that's sort of what I was covering now. So I think that's certainly, okay, so there's a lot of work going into trying to understand what men want, which I think is great. So PSI in South Africa has done huge projects, really systematically and thoroughly trying to understand different kinds. Not all men are the same man. So different kinds of men and what their needs are, and really starting to try, and then from that starting to try to help direct programs that are actually responsive to the way that men want to be treated, what the kind of services that they want and what men want to be, and how they want to be treated. In terms of closing the gap, also it's obviously also to do with offering other services that are useful to men. So offering other services that men want or need, and along the way catching them for HIV testing. I always say, I don't think women by their nature would be going in and out of primary health care services all the time if they didn't have to first prevent pregnancy, secondly manage pregnancy, and then manage a small child. So again, there's been very interesting work in Malawi showing the comparative burden on a man and a woman of the number of normal health visits, just regular health visits you would do in a lifetime. And it's kind of, I don't know, I can't remember the numbers, but maybe 48 for women and maybe 3 for men. It's that kind of thing. So we're also not offering services that will bring them in for something other than HIV. So I think that those are some of the interesting things that are being explored at the moment.
Yeah, absolutely. And in relation to that, Palmi's just said, thanks, Morna. Can you share any links after the talk to the studies you referred to in Zimbabwe, Malawi, South Africa? So
maybe if you just contact me directly, I'll be very, very happy
yeah,
to share.
or what we can do is you can, if you send them to me, and then I can put them with all of with the video and on the links of all the chat. That way they're kept there if anyone wants to access them.
Sure, I'll do that.
So we can do that. Great.
And as I mentioned also, you know, UNAIDS had started what they called a clearinghouse on HIV in men about 2 years ago that hadn't really progressed very far. And so we're actually busy about to start revising that and upgrading that. And really hoping for that to become an incredible resource for people, where they men in HIV and men in public health more broadly, but a whole range of, you know, whether it's the findings from studies and formal reports or videos or interactive material, you know, really to make something that is directly useful both to people working in research, but also to men.
Yeah, absolutely. So we've got a question now by Joanna Busha. So she's saying, do you think the conflation of gender with women and children might reinforce stereotypes that women need protection and thus are always grouped with children, while men are supposed to be competent enough to look after themselves? How can evidence best be used to challenge this reductive approach?
Yeah, I think it's a great question. And I think that really, we do run the risk of doing that. Reinforcing the stereotype that women need protection, you know, women and children. And also reinforcing the stereotype that men are able to and should be the protector, you know. So I think it's hugely problematic. There's some very interesting work that's been done on this. Talking about portrayal, sort of challenging some of that as well, challenging that, you know, because on one hand we talk about women have agency, and then actually if you look at a lot of the kind of global policy documents, certainly stuff around HIV, it absolutely assumes that women have no agency and men are doing things to them. So I think there's quite a bit of work starting to happen on that. Maybe you can contribute to it.
Yeah, and I think also on that, I think it also reinforces stereotypes that women are always associated with children, women are carers of children, and less like putting that kind of care, like sharing the care with men as well. And
that's why I found that study so fascinating. When I thought, you know, 40% of these men actually went with a child. That's incredible, you know, that's or went with somebody else, you know. It so challenges those, what I say, I think so much of what we believe about men is kind of anecdotes that have been repeated and become evidence.
Absolutely, like what you were mentioning about the sort of responsibilization of men, saying that they didn't reach care early enough, they waited too long, or they don't check, they don't talk about their feelings and stuff like that, and putting this responsibility on the individuals and less on like changing the system and the language we use and all of that.
Yeah, exactly, very much so, yes.
Absolutely. We've got two final questions, or at least for now, from Brian. So maybe I'll just ask the first one and then the second one. That way you don't have too many questions to look at. So the first one that Brian Rice asks is, you raise well the challenges we face with recording deaths among people living with HIV and how this impacts on our cascade estimates, for example, retention. What do you think we can do to improve the routine recording and reporting of deaths?
Again, I think if I had the answer to that, I think I'd have a lot of money. It's a good question, Brian. I don't know. You know, to me, it really is. It so reflects the scale of what we have. You know, in sub-Saharan Africa. I'm not sure, but in fact, actually, I think this problem happens also as well, which is also that I think deaths are not recorded particularly well, even in northern countries. So in the sites, obviously, they again have good vital registration, so they can check that. So I don't know, other than increase the human resources who are working in clinics and recording this, improve their training. But you know, beyond that, I think it's a bit of a bigger question than I can answer, I'm afraid.
That's okay. I mean, thank you for trying that out. And the second question Brian asks is, you showed men in care had lower mortality than HIV negative men and suggested something about their HIV care protects them wider. Will this primarily be the diagnosis and management of TB, or do you think it is wider than that?
So TB we know is a huge cause of mortality in men, particularly in men with HIV. It's a huge cause. TB very poorly recorded in our cohorts, or has been. So we couldn't get much about TB. So we know that TB is in there. But what I'm pointing to also is that we didn't set out to test this in my paper. We didn't set out to test it. So we raised this as an interesting comment, was that it seemed that simply being in care was protective against some of the other risks. Now, the risks to me are the risks of, what are men dying of mainly? Violence, road traffic accidents, and suicide. So it seemed to imply that there was something about actually getting men into a system of caring, which in some way protected them against this. We haven't tested that, and I don't know how we would test that, but that was certainly a very strong message that we got from that huge, the distance from those graphs that I showed you. And we just said, hypothetically, it seems as though it protects them from other risks, but we couldn't specify.
Mm-hmm.
Other risks, just being lives for men's lives are much more dangerous. They're much more dangerous than women's lives, just in terms of those external risks. And that's what you're seeing playing out a bit.
Great, thank you. I don't know if there are any more questions. Feel free to maybe raise hands or unmute. Tom, I saw that you've just unmuted. I don't know if you want to ask a question.
Yeah, I just had a quick one since we have a few minutes available. You mentioned how historically the issue's often been a kind of lack of disaggregation of results, when they're presented. So the disparity's not always been obvious. But then you mentioned how even when that does take place, it's not often identified in the findings. It may be there in the data, but it's not focused on. Is there anything that you can think that can be done to kind of advocate that this is identified and incorporated into results?
I wrote I had a letter published in the Lancet challenging it, saying this is skewed reporting, and it's completely unscientific, and I don't understand how they got away with it. So I think if we see this, I think people need to start challenging it. I think that the more that one does that, the more responsibility certainly journals will take. But I honestly think that from the 80s, 90s onwards, there's a kind of an implicit bias against men. Our whole systems are almost entirely focused on women, and not even all women of reproductive age. It's basically about, women of reproductive age and children. Tiny bit on the side for me, tiny bit on the side for me. So, I think we should challenge it. I think that, part of what I'm hoping to do in the Lancet Commission, which is a commission on gender and global health, is to make sure that the focus, because you can read these, I promise you, have a look at, you can read something which, supposedly is about gender and global health, but will be all about women and global health. And I think when one sees that, as researchers, we should be challenging that. If you're reviewing an article, we review lots of articles. If you're reviewing an article and somebody's writing like this, challenge it. I think at every level we need to be challenging it. And in the Lancet Commission, I hope to really make sure that we question that the whole time.
Thank you.
Yeah, thank you for that, and for the good advice. I think now we don't have any more questions, and that's perfect. We're just arriving at the end of our time. So I think I'm just gonna wrap it up. I wanted to say thank you again, Morna, for just a great discussion and answering those questions so well, because some of them were a bit complicated, but you handled it very well. And just, thank you to everyone as well who joined. I hope you enjoyed. So the recording will be up on the website next week, as well as we'll have the Q&A and the articles that Morna's mentioning. So please share with everyone, with your networks, because this is an important topic and it'd be lovely to get this discussion. We'll keep this discussion going. And just as a bit of information, our final webinar within the series is happening mid-December. The date is to be confirmed, but it will be presented by Shona Dalal from the WHO. And information about this final webinar will be up on the website later this month. So make sure to keep having a look at our Twitter and website. So the links that Tom put in the chat at the beginning of this talk. And thank you again to everyone who joined in. Thank you to Morna.
Can I just say one thing? There's lots of interesting material on this, and it covers so many different issues. Anybody's interested in following up on this and would like to get hold of me, please feel free to do so. My email address is morna.c CORNELL @uct.ac.za, and I'd be happy to be in touch with you. I welcome any interest in this field.
Did you say uct.az?
AC.za.
Great. So I've just put that in the chat, and somebody's asked to share the links again. So I'll just share those links again.
Yeah.
Just so you have those. And then those will be on our websites and Twitter, all of the information. So thank you so much, everyone, and have a lovely rest of your day. Thank you. Bye.
Bye.
Gabriel.